first thing I'm going to do is just give you a quick appraisal about what GIST Cancer are doing as a charity, and then I'm going to talk to you about a trial which is quite specific, and I might need to call on these guys' help because some of these slides are quite technical, if they can help at all, but we'll get to that in a second. So we had a board meeting yesterday. We have 4 a year. Basically, we look at the strategy for GIST Cancer UK, how we want to present things to our community, what our priorities are as a charity. So if I start with what our priorities are, our main priority, it always has been since Judith Robertson set the charity up in 2007, which is to support patients and carers. So that is to give you the opportunity to come to meetings, to use our helpline, which many of you no doubt have already phoned, and many of you probably have even spoken to Judith on the phone as the first port of call. I did when I was first diagnosed. I called the helpline and spoke to Judith. She's really experienced, really helpful, and that put me on the road to coming to these type of meetings. So that's always been our priority, and we still hold 3 conferences a year. So we do one in the south, that's this one this time of year. We're either in London or Southampton or Bristol or Cardiff, and then one in the north as well, as in Leeds, Sheffield. What did we decide the next one? Was London for the next one, and then Sheffield after that, I believe, yes. So, and then we do one in Scotland as well. So there's a couple of people that I've seen in the room that come to Scotland. But we fly up to Scotland and set up a patient meeting because obviously there are patients up there. And sometimes we get people coming over from Ireland as well. So we try and reach as much of the UK as we possibly can. We also produce literature and leaflets, and you'll see the table over there that's got our GIST for Beginners, which we've just updated actually. So those of you who've seen them before, you'll probably notice a change in that. So it's a bang up to date leaflet, and there are no stomach and what's the third one? Oh yeah, eating after GI surgery. So a lot of us have operations in our stomach, so that's a very useful one for that. We've also got other bits of merchandise there. We're a charity, all volunteer based. None of us are paid to do anything that we do with GIST. We all do it voluntarily, every single one of us. So the way that we run and hold and host these meetings is purely through voluntary contributions from patients, carers, and so we've got some fundraising information there if you wanted to do a fundraising campaign. By all means, help yourself to any of the wristbands, badges, things that go into shopping trolleys, I'm told. Means that you can't get away with nicking a shopping trolley. Why would anybody want to do that? But anyway. And there's some bags for life as well there, and we have a contribution box there if you'd like to make a contribution. And we are right up to the 21st century. We have a credit card machine as well now, so I'm told. So if anybody did want to do a donation to us, then we do have a credit card machine outside, so we can do that as well. And I think, Mark, you're in charge of that, aren't you? Yeah, there you go. So, yeah, the meeting yesterday, we talked about how we're going to continue to do these meetings, and we committing to do at least 3 meetings a year, committing to keep on top of all our literature, updating them when required. We regularly look at them because things change. We're going to look at more at our one that offers nutritional and dietary advice, so that will be being renewed and updated fairly soon. And of course, the other thing that we do is research. And we've just agreed 2 joint research projects with Sarcoma UK. So GIST is a sarcoma. Sarcoma UK is a separate charity that Judith used to be a trustee of. And then welcome to our new arrivals. And she decided to set up a separate charity, GIST Support UK as it was then, because GIST has the largest cohort of patients with sarcomas are GIST patients. So sarcoma itself is very rare. Having a sarcoma is very rare. Having a GIST is also very rare, but it's actually the largest number of patients that have sarcoma have GIST, something like 900 patients a year. So only a very, very tiny proportion of the total number of people that are diagnosed with cancer. I'm also a trustee of a charity called Cancer 52. Now the 52 should actually be changed to 56. the 56, as it should be, represents the number of people that pass away from having a cancer in the rare and less common cancer sphere. So more people die of rare and less common cancers than they do of the most common cancers. So my role within Cancer 52 is to promote the fact that we want more spending from government on rare and less common cancers, more understanding of the disease, more doctors that when they go through their medical training, they understand more that there are rare and less common cancers are there, as well as the top 4. They know that, but because there are so many, we're trying to increase the amount of information that's given to them so they can recognize that somebody might have a rare and less common cancer. So I spend a lot of time on behalf of that charity, again as a volunteer up in Parliament. So that's the sort of a secondary role that we do, and obviously that feeds into what we do in Just Cancer UK. But the 2 research projects are in collaboration with Sarcoma UK, and they're 2 important projects, and we'll be reporting on them as and when they go through. They're quite technical, so I won't bore you with the detail of them, but they're aimed at trying to help us understand a little bit more about the way GIST cancer works, what treatments there might be for them, any new innovations. So we're always looking at research projects to help us all with, hopefully, the Holy Grail to find a cure. So, right, now I'm going to talk about Strategist 1, the IDRX42. Now, this is a trial that is currently on in America, but it's a trial that they want to now bring over to the UK. And as you can see at the bottom, it opens in May 2024 at the Royal Marsden. And Professor Robin Jones is the lead clinician on this. Some of you might know Robin Jones. I don't know if anybody's come across Professor Jones, but he's one of what we call an expert within GIST. So he's taken on that trial on behalf of IDRX42. So forgive me, because I'm going to read a lot of what's on here. And as I say, please jump in if you feel there's anything that you can add to what's being told. So, as I said, Strategist IDRX42 is a phase 1/1b open label first in-human study of IDRX42 in patients with metastatic and or unresectable GIST. Phase 1a portion of the study enrolled patients in escalating, so this is in America, escalating dose cohorts in a standard 3+3 design. What's that? Any ideas? Okay, so it's an increased dose design, yeah. Phase 1b is open for enrolment in the UK and the EU in May, although I'm told the Royal Marsden is the very first extra place that they're going to be doing it. 1 or 2 dose levels selected using tablet formulation, so much like anybody that takes most of our drugs, they're in tablet form. Suitable for late stage development and commercialization. Dose 1, dose 2, up to 30 patients across 4 planned cohorts, and I think they're aiming to get about 20 patients in the Royal Marsden. So to acquire additional safety, PK and response data. Pharmacokinetics. Yeah, okay. Okay, next slide, please. So history and target, so result of a 10-year discovery program, because obviously you realise that these things started this sort of trial started a long time ago, and it's now coming to that stage where they're trying to make it such that it could be available if it works the way they expect it to. So it's designed to overcome limitations of current therapies, which either do not provide adequate cover or are not selective, resulting in toxicity. And at the moment, the selection drugs that we have, imatinib, sunitinib, regorafenib, the toxicity gets worse with those drugs as you move down those cohorts. So they're trying to find something that's a little bit better for that. With a 3-pronged target profile designed to substantially improve clinical benefit, oral KIT inhibitor. Some of this, for the new people in the room, will hopefully when we have our talks, this will become a little bit more understandable. Activating mutations on exon 9 and 11, and substantial coverage of all clinically relevant AP and AL resistant mutations, particularly exons 13 and 17. Highly selected over key off targets, providing a wide therapeutic window. So the target for multi-year durations. Right, next one, please. So phase 1 informed the dose selection for phase 1b. So what they learned from phase 1 told them how to then take phase B forward as an enabler to 4 planned cohorts. So objectives: to evaluate preliminary anti-tumour activity, safety and tolerability of IDRX42, and characterise the PK and pharmacodynamic profiles. I can't believe I got that word straight off. So cohort 1, participants who have progressed on imatinib only and refused or are ineligible for other SOC therapies. Cohort 2, participants who have progressed on both imatinib and sunitinib, or progressed on imatinib, sunitinib, and an additional agent, i.e. regorafenib or ripretinib, which is the 4th line drug, or progressed on imatinib, sunitinib, regorafenib, and ripretinib, 5th line. There's quite a lot there, but cohort 3, participants who are treatment naive and refused or ineligible for other therapies, only open in the US and UK. And cohort 4, participants who meet the same criteria as cohort 2 and have also had prior treatment with investigational agents or a line of therapy of that plus sunitinib combination. Bezuclastinib. There you go. So this is the important bit. So this is the bit that if you feel that you might be somebody that and we can give you some more details about this. I'm just giving a presentation on this as we see it now, but we can talk to you a bit more about it. But if you feel you might be into one of these criteria, let us know and we can tell you what to do next. But it's basically over 18 years of age, forget that next bit, histologically or cytologically confirmed metastatic and or surgically unresectable. So gone to a different area of the body or not able to have it removed. Documented progression on imatinib, so you've taken imatinib, but the tumour has continued to grow. Documented pathogenic mutation in KIT and or PDGFRA mutation other than exon 18 mutations. This sort of stuff you'll get from your histology reports. The thing to do with this is, if you feel you might fall into these, talk to your oncologist. That's probably the advice that I would give. At least one measurable lesion for participants with GIST. Forget the next one. Yeah, okay, so the exclusion criteria: any prior treatment with investigational agents or a line of therapy of bezuclastinib plus sunitinib combination. GIST, it is both KIT and PDGFRA wild type, so they can't use those patients. Primary brain malignancy or known untreated or active central nervous system metastases. It's very rare, that is, isn't it? Yeah. Has an active uncontrolled infection, including but not limited to the requirement for intravenous antibiotics. Has significant uncontrolled or active cardiovascular disease. So they're all fairly specific. Okay, next one. So facts for potential participants. Participation is voluntary and you may leave the trial at any time. All costs related, site visits, etc., are covered by IDRX and will cost participants nothing. IDRX will also reimburse reasonable study visit related travel expenses. You'll have at least one visit to the site to check your eligibility during the treatment period. And as long as your cancer is not getting worse and you're feeling well, you may be on trial for about 18 months. There's some really lovely pictures of patients that presented with a fairly large tumour and some information about what it did to them. This is the convincing you that it has got opportunity to work. So 71 centimetres reduced down to 44 centimetres. Okay, next one. This is the last one, I think, isn't it? Yeah. This is just another example. So basically, it's fairly specific patients that have had a tumour and have, with imatinib, has stopped working. But as I said, we can talk to patients that if you feel you might be within that cohort, come and speak to us afterwards and we can take this conversation a bit further.